Welcome one and all to this Saturday evening of knowledge and enlightenment. So we are going to talk about learn A to Z of IUI with the experts under the aegis of Nova IVF. And this is a webinar brought to you by Bridging Bharat Initiative by Bharat Serum. So first, we have a galaxy of stars. So let me first introduce Dr. Rohit Gudgotia, who is the Medical Director for Nova IVF Fertility East, a chain of IVF clinics in East India and Bangladesh. And his areas of interest are infertility and setting up standards. Welcome, Dr. Rohit Gudgotia. I would like you to please take the proceedings ahead. Thank you.
Thank you, Session. Am I audible?
Yes, sir, you are.
Yeah. Hi. So, welcome all of you. As Session put in, Nova IVF Fertility East, that's a collection of IVF centers in East India and Bangladesh. We've tried to put together a few common topics that we all encounter during our daily practices and have arranged for what we call fireside chats. These are freewheeling panel discussions that we've organized for the practicing gynecologist. So, of course, the evidence would be there for all of us to look at, but primarily it is real-term, real-world experience of practitioners who are dealing with fertility patients day in, day out. And of course, during this 1 hour or so of chatting, if you have any questions specific related to this subject, you're most welcome to put in those questions in the chat box, and we can obviously come back and address to those questions. Today, the first of the session is on IUI, intrauterine insemination, the commonest performed ART technique all across. And to help me on this topic, we have four very, very well accustomed to this practitioners. I have Anindita Singh, who is my colleague at the Kolkata Nova Fertility Center. She is a graduate from Burdwan Medical College and has been practicing IVF now for almost 5 to 6 years. She is the one who would go to for ovulation induction and stimulation protocols. Next up, we have Dr. Anju Bajoria, an old colleague of mine. We've been working together for 10 years now. She's a consultant gynecologist and fertility specialist in the city of Jamshedpur. She is the director for Srishti Industry Conception Care Clinic, and her areas of interest are infertility and high-risk pregnancy. Welcome on board, Dr. Anju. Third is Dr. Hasna, our foreign delegate. Dr. Hasna Hina Parveen heads the Dhaka unit. She is also the assistant professor in the Department of Obs and Gynae in Bangabandhu Sheikh Mujib Medical University in Dhaka, which is the referral unit in Dhaka. She is a senior consultant working with us at Nova IVF Fertility for more than 5 years now. She is trained with us in our lab and also in Bangkok and London with Anil Gudi and others. Welcome, Dr. Hasna. We look forward to your active participation. And making up the team, last but not the least, of course, is Shatabdi. Shatabdi has been working with us for the last 3 years. She's a consultant in our Shiliguri unit. She has done her fellowship in reproductive medicine after post-graduations from Bombay. She has a keen interest in teaching, spreading awareness, and trying to remove the stigma and the misconceptions which center around infertility. Today, as we said, we are going to talk about infertility. And for that, we will invite all our participants, the four of them, to share screen with us and share their thoughts and their knowledge with us so that we can all learn and benefit from their experiences. To set the ball rolling, is the screen visible now?
Yes. Oh, so it's not yet.
Not yet. Are we visible now?
Yes, sir. Yes, sir. Yes.
Good. Right. So to set the ball rolling, I'll start off with a few slides of mine. Basically, as we understand, IUI is something that is very, very basic, but it has a lot of issues, the fine points of fine tuning that we are all always interested about. There must be at least 8, 10 webinars that have happened over IUI in the last 10, 12 days that I have personally followed. But every time you feel that maybe some more information or some more knowledge in the same topics would have helped. What we have done today is we've sourced our information and our content from these 3 papers. This one is by Gautam Alabadia in the journal of the Foxy Journal, which was published in 2018, 2017. Then this is a paper published in Journal of Human Reproduction in 2012. And then there's the third paper, which was published in 2013 by William Embellett on the same topic, evidence-based recommendations for IUI in daily practice. The reason why I come back to these references is that it's open access. Anybody can actually go and access them and kind of read up on them to be better informed. So my first question, as we set the ball rolling, is to the foreign delegate, Dr. Hasna. Dr. Hasna, you are an IVF practitioner. My question to you is, in today's scenario, when IVF is much more surer, do you see any role for IUI? And if yes, then who are your IUI patients?
Yes, yeah, I think IUI is a more simple, cost-effective, non-invasive first-line therapy, and it is mainly I'll do for number 1, unexplained infertility, and mild to moderate male factor infertility, and also mild to moderate endometriosis, and some other factors such as cervical factors. Or sometimes I also do when husband is staying abroad for a long time. In that cases, I will plan for IUI.
Right. So Bangladesh has a lot of these husbands working abroad. So yes. We call it the Dubai syndrome in India. We should call it, in fact, the Bangladesh syndrome, because almost 50% of the working population in male population is actually working outside. So for them, this is a important consideration.
For indication for IUI, yes.
Absolutely. My question to you as a follow-up on this is that when you talk about anovulatory infertility or mild to moderate male factor, or even you mentioned endometriosis, yes. Do you also look at the time of married life or trying active life? You have a cutoff in sense the age of
yes.
the person.
Yes, it is very important. When a couple come to me, at first I'll see their duration of infertility and the age of the woman of this of the couple. If duration of the infertility is less than 2 years and woman is less than 35 years, then first I will counsel about the try naturally. Then I will go for IUI after 2 years.
Okay. So I'll come to this a little later. But Dr. Shatabdi is one person whom I've seen is very, very partial towards doing IUIs. She feels that IUI is a nice stepping stone to motivate patients to get into rather than an IVF per se. So would she like to add to this? She has anything to add to this?
So as Dr. Hasna said, IUI is comparatively a cost-effective therapy for many of the couples. Especially, I would just like to add here that in the setting that I work in over here, I have a lot of couples who come to me who are maybe the affordability part is always there. So most of them will need some time to arrange the money before, even if they are money indicated for IVF is indicated in them, they would require some time to arrange that money. So most of the times I use this time to as a waiting period. When I am waiting to do IVF on them, maybe in the meanwhile they can go for a couple of cycles of IUI, because then it's better that way. They get time to arrange the money for IVF, and then we get around say 8 to 10% of people who conceive in this waiting period with IUI. So then that way I like
which is a fair call, doctor. I thought you would also mention that IUI works as a nice stepping stone. It helps to acclimatize the patient towards the world of fertility treatment, because not always the patient is conditioned into getting into the world of fertility treatment with folliculometries and triggers and this and that. So maybe an IUI is a nice stepping stone. They can get to know the doctor better. Anindita and Dr. Anju, I must mention out here that I have 4 doctors with 4 different practices. Dr. Anju is a standalone practitioner doing inseminations as a part of a practice. Dr. Hasna, Dr. Anindita, and Dr. Shatabdi are all IVF fertility specialists, but they're also doing IUIs. Dr. Anindita has a lot of referral patients as well. A lot of the doctors in this part of the country refer patients to Dr. Anindita. My question to Dr. Anindita is, how do you see the uptake of IUI in your referral population? Meaning, how comfortable are your referring doctors in the sense referring for an IUI or wanting to do an IUI themselves?
Okay, the doctors are pretty happy that they would also like to refer for IUI because as Dr. Shatabdi mentioned, it is a very good first line therapy too, and for patients who are actually indicated for an IUI, even for those patients, a lot of them conceive with an IUI. So the referral pool is pretty good.
Okay. I would also feel that some of them would be eager to start doing their own IUIs. Is that it, doctor?
Yes. A lot of doctors are willing to start doing IUIs, and some of them are also coming down to our clinics. We help them out with the stimulation protocols and with the folliculometries, and they're also coming down to our clinics. They want to do the IUIs, and a lot of them want to set up their own IUI centers, and we are also helping them with it.
In Dhaka also, there is most of the gynecologists, they want to do IUI by themselves.
Okay, which is a fair thing, because I feel that the gynec feels more in control if they are able to perform the inseminations themselves. My question to Dr. Anju, we have seen the transition of Dr. Anju from a standard gynec to a now a full-fledged fertility practitioner. So what motivated her to take up IUI practice, and what was the first and the foremost trigger point that she was wanting to start doing IUIs? Dr. Anju?
Yeah, because the IUI practice is not very standard in all the clinic. Everybody is doing IUI, but they don't do the perfect, the optimized IUI, you can say. So that was the reason, because patient used to come to me. But IUI with the standard protocol, you can say, with a proper ovulation induction, follicular monitoring, and proper preparation of insemination. And the first one thing in my place, that everybody is not preparing semen in their own clinic. So the patient is going somewhere else. The time period is so much, and they come back, and they don't maintain the time period in which we should do the IUI insemination. Seeing all these things, I felt that I should go for starting IUI practice in my own, and then further to IVF.
How is your experience being? Are you happy now that you've been doing IUI for 7-8 years now? How many pregnancies have you had, and how's the pleasure of having somebody conceive with your own pregnancies?
It's really very good. I mean, I can't say when a patient gets pregnant after, and for 2 or 3 IUI, you won't believe it was the 6th one. And it was a patient's like, no ma'am, you do it. And they got pregnant. So I really feel at the top of the world.
That's
really satisfying. It's
not
very
the money,
satisfying.
It's not the money always. It's always the sense of pride that you have, the sense of achievement that you get.
Very true.
My 2 points here to the people who are listening in. Thank you for tuning in. So first and foremost, please understand that IUI is a low success game. Hardly 10-12% pregnancies are achieved on a per person per cycle basis. What we need to understand when we are starting out is, of course, stick to the basics, which is what we're going to cover tonight in the next 1 hour. At the same time, make sure that you select your patients properly. If somebody is successfully performing IUIs, and that's Dr. Anju for you, Dr. Hasna for you, Dr. Anindita, Dr. Shatabdi for you, they are doing it because they are selecting their patients properly. They are not having out of this world expectations. They are having real expectations and real selections of the patient. That, of course, brings me to the next question as to who is an ideal IUI candidate for Dr. Anindita.
Okay, an ideal IUI candidate would be a lady who has been married for some time, around 2 or 3 years. She has tried to conceive naturally, but she hasn't. She may be having, the couple may be having mild.
We have a glitch here. Would Dr. Shatabdi want to take this question?
Yes, sir.
Yeah,
Yes.
please.
Yeah. An ideal couple for an intrauterine insemination for an IUI would be, like Dr. Anindita was saying, maybe a couple who has been married for 2 to 3 years and basically coming to unexplained. When we have done all their tests, the tubes are patent. The male factor is not there. There is no male factor. The lady is ovulatory. The lady is ovulatory normally with regular menstrual cycles. This would be an ideal couple for IUI. Also, a lady whose female factor is completely ruled out, but of course with an azoospermia in the husband. So that would also be an ideal couple for an IUI.
For donor insemination.
Yeah, for donor insemination, of course, for donor
Correct.
insemination.
Correct.
And as I said, patients who are willing to wait, who are just buying some time till they can actually go ahead with an IVF with more or less all the factors ruled out, grossly everything to be fine. So these would be ideal couples for.
I would agree. This is this wonderful publication. It's a slightly dated publication, 99 publication, but they've done a wonderful analysis. They've looked at the age, the duration of infertility, the etiology of infertility, the type of infertility, the sperm count of the partner, and the progressive motility. I would say this 1, 2, 3, 4, 5, and 6 points would pretty much sum up your ideal candidate. She has to be young. She has to have a short duration. It's best to select unexplained infertility patients for your inseminations. And of course, she is secondary infertility. It works better for us. The count is good. The motility is good. That works better for us. Dr. Anindita, as they say in television, we lost the link with you. So maybe the next question will go back to you once again. So for the first section of the presentation today, so well selected is almost half done. And after having selected properly, then we move on to the next section, that is the stimulation of the candidate. Before that, I'd like to point out that there was this wonderful paper that was published by Hunault, and he prepared a scale or a scoring system where he looked at the female age, the duration of infertility, the fertility problem in the man's family, the postcoital test, again this is an old paper, and the motility. And looking at all that, he provided with a score which kind of helped us to classify the patients into the easy candidates and the difficult candidates. This is a publication in a couple of years back where they looked at review of IUI and systemic assessment of the evidence that supports global recommendations. And these are the clinical questions that they have kind of asked. So the first question is what we've already done. What are the indications for IUI versus intercourse or expectant management in infertile couples, and when should treatment be initiated? So essentially, if the candidate is an easy candidate, she should be allowed at least 6 months of trying time before we move on to IUI. If, however, she is a difficult candidate, but not so difficult, then we can start off the IUI immediately. Do we stimulate in our patients? In practice, yes, we do that almost 100% of our patients. What are the influence of sperm quality on IUI outcomes? Can we define the threshold levels of successful IUI? No, it's not possible to provide a clear cut, not possible kind of a cutoff, but higher the better. What is the best timing of insemination in IUI cycle? What is the optimal method of timing in natural or stimulated IUI cycles? So these are the common questions that play in people's mind, and the next few slides will do them one by one. So ovarian stimulation, Dr. Anindita, I'm coming back to you because you missed out on the last question. So this, I think, is your home turf. How do you like to stimulate your patients? How do you see natural versus clomiphene versus letrozole versus gonadotropin? Who's your letrozole candidate? Who's your clomiphene candidate? And who's your gonadotropin candidate?
Okay. So for good prognosis patients who have a shorter duration of infertility, we can also do a natural cycle IUI. But when the duration of infertility is more than 2 to 3 years, it is always better to do ovarian stimulation. So I would like to stimulate the patient with clomiphene citrate at a dose of 50 milligram daily, starting from the second or the third day of a period. And I would give 50 mg daily for the next 5 days. After 5 days, I would then do a folliculometry scan and assess how she has responded to the clomiphene citrate. Alternatively, in some cases of clomiphene citrate resistance, I also do opt for letrozole Letrozole I'm giving at a dose of 2.5 milligram per day. Again, I'm starting from day 2 or day 3 of her cycle and continuing for the next 5 days. After that, we again scan her on day 9 or day 10 of a cycle, and then we see whether she has responded or not. Gonadotropins, I'm usually using gonadotropins when there is poor response to either clomiphene citrate or letrozole. And after scanning her on day 10, if required, I can add gonadotropins. In many cases, when I have got a poor response in the previous cycle, the patient has not responded and we have not achieved a proper follicle. In those cases, many times we do start off with gonadotropins from the day 2 or day 3 of the cycle 2.
Right. Dr. Hasna, I think it was a beautiful summary. Thank you, Dr. Anandita. Dr. Hasna, you and the practice in Dhaka, you have been using letrozole for quite some time. We have started using it for last couple of years, but you have been using letrozole for quite some time. Yes. Can you just comment about the role of letrozole in your practice? How dependent are you on letrozole? Are you still using clomiphene? And what's your standard dose of letrozole for your patients?
Thank you. Mostly, I prefer the letrozole than clomiphene. I usually use letrozole because it is monofollicular development and it is the good effect in endometrial thickness. So always I prefer letrozole.
Right. Do you use it once daily 2.5 or twice daily 2.5? What's your standard dose?
Usually my starting dose is 2.5 milligram twice daily from day 3 to day 7 for 5 days. Usually I will give this dose, then I will give a scan at a day. In case of IUI cycle, then I will give TVS at a day 9 or 10. Then if there is no good follicle, then I can add this with gonadotropin.
Okay, perfect. I would not spend much time on the stimulation protocols in IUI, primarily because that's something that all of us, whoever is a gynecologist dealing with fertility problems, has been doing for a long time. And luckily, most of our patients, whether they are given clomiphene or letrozole or even gonadotropins, they tend to have almost similar results insofar as the pregnancy rates are concerned. This is a huge study carried out in China. They have huge numbers, remember. So they've looked at more than 8,000, 9,000 patients, and they've come back with pregnancy rates close to 9% for CC, 9.4% for letrozole, and 9.5% for gonadotropins. So there's not much to choose between these, I would say. Now, of course, there would be specific nuances of using letrozole and clomiphene. Be prepared, because I've already got something like 20 questions that have come in from the very active audience that we have today. And I'm sure my doctors would be up to answering those questions. So we'll run through our slides and then we will see how those questions pan out. Timing. So I think that the main crux of the successful IUI program is not the stimulation. That's something we all do. It is the timing. And there are so many timing issues that we have to look at. We have to look at the triggering. When do we trigger? Then we have to look at when we trigger and when we do the insemination. Then we have to look at sperm preparation versus insemination timing. Then we have to look at when to start the luteal support. So there are so many timing issues. Should we do a pre-rupture IUI or should we do a post-rupture IUI? I'll break the questions. Start off with Dr. Shatabdi. So Dr. Shatabdi, when do you trigger your patients?
Sir, I usually trigger my patients when I have 1 or 2 follicles between 18 and 20 millimeters. And recently I've started also looking for the blood supply to the follicles. So I just have a look at the peri-follicular Doppler. And if around 3/4 of the follicle I see proper my blood supply, so then in that case I decide to go ahead with the trigger.
Which is a very fair call. And the next follow-up question to Dr. Anju would be, how often are you using gonadotropins? Do you see any difference in triggering habits between clomiphene-induced or letrozole-induced cycles and gonadotropin-induced cycles?
Yeah, when I don't get proper follicle, then I add gonadotropins with my letrozole combination. And for the ovulation trigger, if I'm using gonadotropins, then I let follicle to grow till 18 millimeter. And with clomiphene, I go for around 22 millimeter.
So that's
And
again
then,
standard practice, I would say. Most doctors and most
right,
clinics would be doing the same thing. Whether it's
yeah.
20 or 22, it's more a matter of personal comfort rather than anything else. Dr. Anindita, I'll butt in here. Do you trigger all your patients or you go by LH surge? If you remember, in our starting days, we used to do a lot of LH surge. We've stopped doing that mostly. So what's your experience of endogenous LH surge triggered cycles versus HCG triggered cycles?
Okay, I always prefer HCG cycles. I am administering HCG trigger to the patients whenever I see a follicle size of 18 to 20 millimeter. I'm not going much for the LH surge.
Okay, so there's this publication where they compared LH surge cycles versus LH surge followed by HCG cycles versus HCG cycles, and they kind of came back and said that the results are mostly equal, so does not really matter. However, the trigger does help to time your patients better, so that way logistically it's a much better approach. Now, if HCG has been given, so you've actually decided to trigger her with HCG, standard dose would be 5,000 international units. Dr. Hasna, when would you want to do the insemination?
Yeah, after if HCG trigger is given, then yeah, I usually given 36 to 40 hours after HCG trigger, single IUI.
Okay, so again, that's something that we have to remember. The timing of the insemination is very, very important. Most people still stick to 36 to 40 hours. If you go and search the web, you'll get all kinds of evidences. Slight delay is slightly better. Some say that no, 36 to 40 is good enough. This is a paper which is like a couple of years old, and they have also come back and said 36 to 40 hours is better than more than 44 hours. So continuing the same note, my next question to you, Dr. Anindita, is, do you actually document the ovulation and then do the insemination, or you do the insemination and then call the next day for documentation of ovulation?
Okay, now I'm usually documenting the ovulation and then going ahead with the IUI.
Okay, so I would say the rest of the panel are doing the same thing, is it?
Not always.
Not always.
I'm not always.
Not always.
Just give trigger, then come
Okay.
for the next day.
So this paper there says that most probably the clinical pregnancies are slightly better. There's a smallish group of 270 patients where follicle was checked to be ruptured and then insemination was done. So they've claimed almost 3 times more pregnancy rates in a documented ovulated IUI cycles versus a non-documented IUI cycles. So this is something that's a food for thought for all of us. This is again something that has been there for donkey's years. Single insemination, double insemination. Dr. Shatabdi, for the benefit of the viewers, what is your practice, and do you stick to it or you have changed your practice?
Sir, I usually go for single inseminations. I mean, as we discussed, after the HCG trigger, 36 to 40 hours. There are some cases where very few cases where I have gone for a double insemination, where maybe there were multiple follicles, say 2 or 3. On the day of ovulation, I also usually like to document the rupture. So if I have seen one which has ruptured and maybe one more which has not, so then I do an IUI that day, and I would call the patient again on next day to document ovulation of the other follicle. And then in these are the times when I have gone for a double insemination. Otherwise, it's standard 80 to 90% of the patients, it's a single insemination.
Okay, again, I think this is a very valid answer. All my doctors have sworn to speak the truth and not the evidence. So I'm so happy that they're sticking to what they do in their daily practices and not saying what they're supposed to say. So yes, maybe double insemination has a slightly higher pregnancy rates, but logistically speaking, that doesn't work out too much of an advantage, and we reserve that only for the odd case where the patient insists on a second insemination, or maybe there were multiple follicles, so the second time around we did not see an ovulation, and so on and so forth. I would say that when you're starting out a practice, maybe double insemination that time makes sense, but once you have been matured into a standard optimized practice, as Dr. Anju said, then maybe a single insemination is way to go. This is something which is more for the education of the viewers, that is the sperm preparation time, sperm collection, to preparation, and from preparation to insemination. That's something that you have to watch out for. Dr. Anju was mentioning in her initial introduction that that's something that is not looked seriously enough by the colleague practitioners, and that is one big reason why maybe cycles do not click. Dr. Anju, would you want to elaborate on this?
Yeah, the semen preparation time from the semen collection to the insemination should not be more than 90 minutes. In my clinic, I always call patient to nearly 2 hours before the time of insemination, if I have fixed, and immediately we start preparing. We give 20 minutes for the liquefaction time, and after preparation, we immediately inseminate the prepared semen.
Okay, perfect. So this paper also is saying the same thing. The insemination time should be between 40 to 80 minutes once the sample is in your hands. To support or not to support, Dr. Hasna,
Yes.
do you think that giving progesterone after every IUI cycle makes sense? If not, then why not? If yes, then why yes?
Basically, in my clinic, I always give progesterone support, irrespective of the ovulation induction. That is true. But study shows that if it is gonadotropin stimulation and progesterone is beneficial effect, then stimulation cycle with clomiphene citrate with IUI. But basically, in my clinic, I always give progesterone in all my patients after IUI.
Correct. Correct. Any difference of opinion from any of the other panelists, please?
Sir, couple of times there have been say some couples in some patients where the female is say 20-21 undergoing a donor insemination. So in those cases, a couple of times I have not given progesterone support, and then things were still okay. That's the only difference, only time where I have not given a progesterone support. Otherwise, I give it for everyone.
Dr. Anandita was raising her hand, please.
So I agree with Dr. Hasna. We are giving progesterone luteal support after IUI, but as for the evidence that suggests that in natural cycle IUI, luteal support is not required. Even when we are stimulating with clomiphene citrate and letrozole, even in those cases, it has been said, evidence shows that luteal support is not required. But we are giving, that is the truth. And I was just reading up, and it says evidence says that micronized progesterone is supposed to be the best, even though we are using dydrogesterone, and that is it.
So it's always good to periodically go back to the evidence and read up, and if needed, not always, if needed, you can always have a change of practice. So this is this large impact paper published a couple of years back, which did have some impact on people's practices, where they came back and said that maybe progesterone is not needed in clomiphene-induced cycles, but in gonadotropin-induced cycles, because of the suppression of the corpus luteum, because of the HCG trigger and the gonadotropins, it makes sense to support them with either micronized or the vaginal gel. So I would agree with most of the panelists here. That would basically bring me to the next section of questions, and these are as follows. Have you heard of something called fallopian sperm perfusion? Dr. Shatabdi, Dr. Anindita, Dr. Anju, Dr. Hasna, anybody can take this question. If yes, then do you practice this?
Yes.
Right. But I don't practice the fallopian sperm perfusion.
Okay, so
I have never, yeah.
Dr. Hasna doesn't practice. Dr. Anju?
Same.
I don't
sir.
practice.
I have never done it.
Even I have never done it. I have just read about it.
Okay, so we have all heard about something called fallopian sperm perfusion, which is basically washing the fallopian tubes with a large volume of inseminate, done very slowly. In some cases of endometriosis or unexplained infertility, some initial papers had showed that there could be a higher than normal expected pregnancies. But then this is something which has been discontinued. And this is what the take home is. The interventional FSP, that is fallopian sperm perfusion, when compared to IUI, should not be the treatment of choice. If you were the researcher kinds and you want to practice this in your personal setup, you could do it. But by and large, this is not the go-to practice. What is the optimal number of inseminations? We have done that. Is there a benefit of bed rest after IUI? Again, Dr. Anindita, I'll pick on your brains on this.
Yes. In my clinic, we are giving around 10 to 15 minutes of bed rest after IUI. I think that is what is followed in most of the clinics.
After that, are they allowed to have intercourse and are they allowed to go back to their daily grind? How is it?
Yes, I allow them to go back home, and I rather encourage them to have intercourse during that period of IUI.
Dr. Hasna, you're somebody who's practicing IUI and IVF. So would you want to continue doing IUIs or would you like to stop IUI and move into IVF? What, according to you, is the optimum number of IUIs beyond which it doesn't make sense to flog a dead horse?
Question again. So I don't.
How many cycles would you like to do before you recommend an IVF? What, according to you, is a upward graph, meaning the success rates are there, after which the success rates drop?
I basically want to do at least 4 to 6 cycle, but minimum 3 cycle is needed before going for IVF.
Again, I think that's a fair call. This is what we do in mostly our practice.
I want to do 4 to 6 cycle, but patient would agree to go more than 3 cycle.
Absolutely. So semen preparation, people say that most probably density gradient works best, but then by and large, swim up, density gradient and simple centrifugation is more or less similar. What is the cost effectiveness of IUI versus IVF ICSI? And this is something that I and Dr. Shatabdi have debates quite often. Dr. Shatabdi, how do you place the cost effectiveness of an IUI cycle?
So it will depend upon the indication for which I'm doing the IUI actually.
Very important point, right?
So again, if it's a young girl, as in young female with donor inseminations, I have to go for it at least for 4 cycles before I advise her to go for an IVF. And for other couples, I think again it will depend upon the indications. If I am doing an IUI for a lady with polycystic ovaries, then she is anyways going to need injections, which is anyways going to cost her. So for such cases, I think IVF will be a more cost-effective way of dealing with the couple. But for mild male factor and all, I guess cost-effective wise, 2 or 3 cycles of IUI is good enough. I mean, it is not going to increase their burden a lot before they can proceed ahead with IVF. So it will depend upon the indication for which I am advising the IUI and doing it.
So in our context, I would say that one IUI cycle costs around 1/8 or 1/10 of an IVF cycle, if I'm right. So on an average, let's say the standard patient would be what, 2 cycles of IUI followed by IVF, 3 cycles of IUI followed by IVF?
Followed by IVF.
Okay, so that's the standard practice.
Three cycles followed.
Three. So how do we prevent infection in an IUI lab? So of course you do all the serological tests and then you have a very strict processing system. Now in the COVID era, we have to be more careful about this. How do we prevent multiple pregnancies? Dr. Anju, if you would like to take this question, how do we prevent multiple pregnancies and OHSS, ovarian hyperstimulation in an IUI program? In other words, when do you cancel an IUI cycle for over response?
Yeah, during the ovulation induction, in my practice, when I call patient on the 8th day for the follicle monitoring, and mainly in the case of polycystic ovaries, if I say if the developing follicles are more than 5 or 6, and later on also, I just cancel the cycle on that goal. And I explain patient also, okay, look, this is the reason, and my clinic is only IUI clinic. I can't shift, change her to IVF also. So if more than 5 follicles or 4 follicles are developing, I cancel the cycle in that case.
So Dr. Anju has a threshold of 5 follicles. Someone else may have a threshold of 4 follicles. The message to take home is do what is palatable and possible at your end. Do not do anything that is not possible at your end. Unfortunately, and it is my considered opinion here, that conversion of an IUI cycle to IVF cycle does not translate into a good success. So most patients are not mentally prepared to move into an IVF cycle during an IUI cycle, and a hasty conversion of an IUI into IVF cycle does not always pay good dividends. So cancelling is much better. As regarding triggering with an agonist, HCG, all this has been tried. But if the patient has gone till the trigger point before cancellations has been triggered off, then maybe it's a mistake of monitoring of the patient, because ideally we should have been able to pick up at day 8 or day 10, as Dr. Anju very rightly pointed out, that this is someone who can go into hyperstimulation and should have taken corrective action then and there. Has any of you in the panel seen any congenital anomaly in any of the IUI pregnancies that they've achieved so far? Anybody can take this question.
No, I have not seen.
No. So again, data says that the anomalies are higher than in natural conception, but equivalent to IVF conception. So that's one point again we have to remember, that whenever we go for any form of ART, the risks, even though they may be very small, are still there. So this is something that we have to remember. Similarly, increased congenital anomaly rates after IUI and IVF technologies, slightly higher than natural conception, but equivalent to IVF is what the message is. Now I will come to specific conditions, which are basically PCOS and IUI, unexplained infertility in IUI, and male infertility in IUI. Unexplained infertility, Dr. Anindita, that's your take here. How do you see unexplained infertility patients? Do you do anything special for them? Is there anything trick or any tips that you want to add here?
So unexplained infertility patients are those who have done the basic investigations and they are not able to come to a conclusion as to what is wrong with them. So in these cases, I would go ahead with ovarian stimulation. Depending upon her age and other factors, I would stimulate her starting off with letrozole. I would also like to add gonadotropins to her ovulation cycle.
Okay. I would like to add here to Dr. Anindita's comment here that these are the better patients. Consistently, evidence has showed that these patients do very well with IUIs. Mostly, they should be well timed, well performed, and we should stick to the rule of 3 IUIs to the max. And more or less, the revival of IUI, if that is what we can say, has happened on the basis of these category of patients, if they have been properly investigated and all obvious causes have been ruled out, then maybe these are cases of subtle endometriosis or coital difficulties which are not been expressed otherwise. So these patients benefit immensely from a well-performed insemination. I would come to Dr. Shatabdi here and talk about PCO and IUI. What care does she take when she's dealing with a patent PCO patient undergoing insemination?
So for PCO and IUI, actually, over a period of time, I have now changed my practice. I was initially doing IUIs in PCO patients, but nowadays I have limited my IUIs to PCO patients with only those having the mild male factor or some coital difficulties. So those are the subset of PCO patients that nowadays I have changed the trend and I have been doing IUIs for. But nevertheless, for the patients that I go for an IUI, for the PCO patients, I have started using a lot of these low dose stimulations. I don't use letrozole or clomiphene for the gross PCO patients. I usually start with this 37.5 IU from day 2 or day 3. And I have seen that low dose for a prolonged period usually gives me a single follicle growing at the end of it. Rather than starting at a higher dose and getting multiple follicles and having to cancel the cycle. Because my PCO patients, I will always have a risk of multifollicular development and cancellation of the cycles. So what I have seen is that these low dose for a prolonged period are the ones which will eventually give me a single monofollicular development. So this is the protocol that I have been following of late for the PCO.
So we have the step up protocol and the step down protocol. The principles are same. You start off with a very low dose, watch for 5 days, and then slowly increase the dose so as to be able to achieve a monofollicular genesis. You could either start with a low dose of 37.5 or of 50 IU and then increase by 50% every 5 days till you achieve a dominance. Similarly, in the step down protocol, you start off with a 150 or 112.5, give for 5 days just as a kind of a follicular recruitment dose, and then slowly decrease the dose so that by the time the follicle is ready, the other intermediate follicles have stopped growing because there is no longer FSH supplementation that is happening. So these are the two commonest methods by which we can achieve monofollicular genesis. I would also take this very often asked question here. In fact, that's one of the questions that's asked in the question section, the chat section also, and address this to Dr. Shatabdi, Dr. Anju, Dr. Hisna, and Dr. Anindita all together. What do you see the role of adding estradiol valerate in the clomiphene cycles? Not that we are doing many clomiphene cycles these days, but because there is a complaint that clomiphene causes thin endometrium, do you see any role of adding EV? And what is the consensus here? Dr. Anindita, if you start off.
Yes, there is a practice of adding estradiol valerate to patients who have been stimulated with clomiphene citrate, because after clomiphene citrate we end up getting a thin endometrium. So in some cases I have used.
Okay. Anybody else? Dr. Anju?
Yes. I never added estrogen in the clomiphene cycle. Idea behind this is if the follicle is good, there is no need of adding estrogen in that cycle. If we go for the higher dose of clomiphene citrate, then the anti-estrogenic effects come. In the dose of 50 or 100, we don't get such type of things. And we should think that the quality of follicle is not good rather than the anti-estrogenic thing.
Dr. Hasna, if you have anything to add to this.
Basically, with clomiphene citrate plus estradiol, I never use. I always prefer letrozole, number one.
Okay.
And number two, in clomiphene citrate, I always observe the endometrial thickness. If thickness is okay, no need to give estradiol. If thickness is not good, then we'll prefer estradiol.
Okay. Dr. Shatabdi, any difference of opinion?
I agree with Dr. Anju, sir, that if the endometrium, with doses of clomiphene at 50 and 100, the chances of having an anti-estrogenic effect on the endometrium is not as much. Nevertheless, if you still have a bad endometrium, then I think we should go ahead and counsel the patient that maybe the follicle, the cycle was not good enough. So accordingly, balance way out and then take a call.
Which is a very nice way of looking at things. So there's this beautiful, I would say, innovative way of looking at the effect of estradiol valerate on the endometrial pinopods. And they have come back and said that there is no increase in the number of pinopods in the endometrium expression post addition of EV in a clomiphene cycle. So if you are adding EV to improve receptivity, that may not work. Maybe the thickness may improve, because there are a couple of papers which claim that the thickness improves. Even that is debatable, because the clomiphene induced suppression of the receptors would continue for some time, because clomiphene is a long acting molecule. But then they have looked at the ultrastructure of the endometrium, looked at the pinopod expression, and come back and said that the number of pinopods do not increase with addition of EV in a clomiphene cycle. Premature LH surge is a tricky business. Dr. Shatabdi, we had a pre-panel discussion pact that you will take this question and answer and explain it to us.
Sir, premature LH surge is a confusing topic to begin with. I think to diagnose premature LH surge is in itself a challenge. For me to know that this female is having a premature LH surge, by the time I diagnose it, maybe she's already had the surge. So there is no way I can rescue that cycle. So I would like to limit this premature LH surge patients based on my suspicion and based on the patient profile. As in patients with multifollicular development, patients with PCO, I would like to, with my suspicion, I would think that maybe these are the candidates who can go for a premature LH surge.
Very well put. Absolutely correct.
So for these patients, there might be a slight role of adding a GnRH antagonist in the next cycle when the follicle, say, reaches around 14 mm. But although I went through some studies which show that there is not much effect of, I feel personally it's an overrated thing. We should not think so much about it. We can
Absolutely.
just
On a personal note, I share your opinion here. So yes, there is a condition known as premature LH surge, which may happen in some PCO patients where the follicle has stopped growing after a while, and the endometrium is looking all ready and ready to go, but the follicle is not growing, and the progesterone levels are slightly on the higher side. And if you check the serum LH levels, they're also on the higher side. But then this is a diagnosis like luteal phase defect. This is a diagnosis of retrospective
exactly.
effect, and you cannot do anything in that cycle. To be aware of this condition is more sensible, and you should be prepared that some patients may have this kind of a response, and in those patients maybe adding an antagonist along with the gonadotropins may help you to overcome this condition. Thank you, Dr. Shatabdi, for making this so clear to all of us. Male infertility in IUI, I'll come to Dr. Anju on this. Dr. Anju, do you perform inseminations for poor sperm parameters? What is your cutoff? We have so many questions about male infertility. Do we have to prepare the semen? What technique? Do we take all, or we take only the motile sperm? I'll summarize this. Basically, do you still use IUI for poor sperm parameters? If yes, to what extent?
It's a mild factor, mild factor of male infertility. I go for IUI.
So how
At least I should have minimum 10 million count motile sperms in the semen analysis.
Okay.
And
so in the raw sample, you expect 10 million, and in the washed sample, the
minimum 5 million, I should
minimum
say.
5 million. Yes. So theoretically, you could have pregnancies for 0.1 million also, but in real life, real world, 5 million is what the cutoff should be, or ideally is what it is like. I would agree with you here. One point we have to remember, of course, that whenever we do a Cochrane review, we do not identify whether IUI is at all effective in moderate to mild infertility, male infertility. And second thing is, it is either the morphology or the DNA integrity of the sperm that is of more of a concern, and these are things which cannot be assessed on a very confident level in the IUI labs mostly, and therefore subjecting male factor infertility to IUIs is not really a common sense thing to do. A significant correlation between sperm DNA damage and achieving a pregnancy. This paper was there, and they've concluded that sperm DNA damage is strongly correlated with pregnancy outcomes in couples undergoing either timed intercourse or IUI, and this is something that is not checked even now on a routine basis. So this is one of the explanations why IUIs fail. Unilateral tubal block in IUI, Dr. Hasna, do you perform inseminations in patients who have unilateral tubal block?
Yes. If unilateral tubal block and other tube is okay, then after counseling with the patient, then I will do IUI. And also counseling about the patient that when I stimulate the cycle, if the follicle in the tube is not developing, then stop the IUI. And I should counsel this patient before the IUI.
Okay, so you have a
I'll go for IUI with one tube, and also counseling the patient about this whole scenario.
So you have a higher cancellation rate for such patients, but you do perform insemination. So yes, if the patient is young and has been counseled properly, both about the increased chances of ectopic and failure rates, then I don't see any reason why we should not perform inseminations. There is this paper published last year, 2018, where they looked at single tube block versus bilateral tubal patency, and they saw that almost similar pregnancies were achieved, especially with patients with proximal tubal block, and those with distal tubal block had less pregnancy rates. Failures. So what are the reasons why an IUI cycle fails? I'm coming back to Dr. Hasna on this once again. Why do IUI cycles fail? How do you counsel your patients if an IUI cycle fails?
There's some there's some factors which success the IUI, and also there's some factors which cause the failure of the IUI. If there's a good patient selection, when patients couple age, basically the woman is less than 35 years, there is a chances of the IUI is less, and it is the improper timing of trigger. Follicle is not mature enough, but triggering is done at the before the maturation of the follicle, and also timing of the IUI is not properly, and poor semen preparation techniques, and faulty, and sometimes the oocyte quality is not good. That is also a cause of failure of the IUI.
So I would agree with Dr. Hasna here that mostly the oocyte quality is not uniform in every cycle, and that's something that we have to guard against and explain the patient before we start the IUI program, that the failure rate is as close to 80-85% in a standard IUI program, and this is something they should be prepared for. Because the oocyte differs from cycle to cycle, it makes sense to do 2-3 cycles before we move on to the next mode of treatment. Thank you, Dr. Hasna, on this. I would like to point out here that there are 2 papers. One is the fast track paper and the other one is the 40 and over treatment trial, and both of them have come back and said that if the initial FSH levels are more than 10 to 15 MIU per ml, or the age of the patient is more than 40, then the pregnancy rates are almost close to 0. So please do not include these patients in your IUI program. More often than not, you will have failures on your hand. I think at the same time, this was pointed out initially by my panelist, that IUI does have a role in low resource countries such as us, where we can kind of take up some of our patients for insemination and get them pregnant through insemination, thus avoiding the strain on resources by performing IUI unnecessarily to them. I would also like to point out here that there should be a cost-benefit analysis calculation that should be done for each and every patient before we counsel them for an IUI or an IVF. Initially speaking, maybe the IUI is a cheaper mode, but if the chances are low, she will still end up spending unnecessarily for an IUI cycle rather than moving to an IVF directly. Now I come to the most important section, and this is a rapid fire section. I will ask the patients, I'll ask my panelists to take the questions as and when they want to. I have 20 questions. Let's see whether we can take them all. Question number 1, how do you decide the dose of HCG trigger? This is from Dr. Ruma Goswami. Anybody, quick.
When you see the follicular size is more than 18 or 20 millimeter, and endometrial thickness is
dose of HCG. Dose of HCG.
Usually the dose of HCG.
Usually dose is 5,000 IU HCG is usually given.
Okay, so we'll
sometimes in case obese patient, sometimes we can use double, but usually 5,000.
So if the BMI is more than 30, you'll go for 10,000, provided she has no risk of hyperstimulation. Otherwise, it's 5,000. Another question from Dr. Ruma. Thank you for tuning in, Dr. Ruma Goswami. Do you consider endometrial thickness or only the follicle size for the trigger?
We do consider endometrial
thickness.
Okay.
It is same, even if it is less, we do get pregnancy, but it has got certain role.
So it's the architecture of the endometrium which is more important than the thickness. If it is a trilaminar endometrium, slightly lesser than 7 millimeters, it does not really matter. However, there are papers which say that every millimeter that the endometrium comes down, the pregnancy rates also come down. Next question, role of adding progesterone in follicular phase to prevent premature LH surge. This is a question from Dr. Asma Rumana Shahid. I'd address this question to Dr. Shatabdi. Do you give
Sir,
progesterone?
I have never used. I have no. I have never given progesterone in the follicular phase for suppression of.
Yes, there are IV protocols where you can use progesterone to prevent LH surge, but that would damage the endometrium, make it non-receptive. So this is mostly reserved for donor cycle programs of patients who are going for a frozen embryo transfer. In an IUI cycle, this cannot be done because in an IUI cycle, you have to do the insemination in that very cycle. So we cannot use progesterone for LH surge prevention as yet. Next question is, which is better for trigger, HCG or decapeptyl? This is again the question from Dr. Asma Rumana Shahid. Anybody?
HCG is better than
HCG.
Okay, so the panel agrees that HCG is a better injection. Decapeptyl or agonist triggers can be given, but it's some initial papers reported a higher miscarriage rate. So that's where we have to look at. Strategy for IUI during COVID times. This is from Dr. Ratul. Dr. Anindita, would you like to take this question?
Yes, we are doing IUI during the COVID times, and we have to be extra cautious in the laboratory, in the sperm preparation, and that is all. We do take care while we are preparing the sample.
The sample has been collected possibly from, we are encouraging home collection more than office collection these days. and that has to be collected into a special container, which is to be sterilized or sanitized after every collection, and after every preparation the working station is also being sanitized separately. This is what we're doing, but inseminations are happening. Dr. Shati has asked this question: do you do IUI for mild male factor? I think we took this question in the course of our discussion. Dr. Asma has another question. What is the ideal time gap between collection of sample and performing insemination? We did that also, ideally 90 minutes to 120 minutes. What is the ideal stimulation protocol for gonadotropins for IUI treatment? Dr. Jayanta Banerjee, we took that question. It is either the step up or the step down protocol. How to increase endometrial thickness before IUI? After triggering, how long you have to go for IUI? Which trigger is better? We have done this question also. We could add estradiol valerate. We could add other methods like nitroglycerin patch and sildenafil. But by and large, ecosprin, by and large, they do not have, if they have any role, it's a peripheral role. They do not have a very big role. Does sperm carry COVID-19 virus? Does semen washing eliminate it? Please enlighten about the strategy of IUI in COVID situation. Again, Dr. Ratul, we have discussed this. So sperm samples were found to be carrying semen sample in a Chinese paper that was published, but post-wash, nobody has been able to isolate the virus as yet. Success in single tube patent from Dr. Farhana Karim Shitu, we discussed that. The pregnancy rates are not bad if it is a proximal block. Can you use agonist trigger or dual trigger in IUI cycles in place of HCG? Dr. Shioli Chaudhary. Dr. Anindita, would you like to take this question?
We are not using dual trigger. We would rather go ahead with a HCG trigger only.
Okay.
But sometimes, I'll add in this, sometimes when we call after insemination, if I call patient to see whether the rupture has happened or not, if it doesn't happen, then we can give a trigger in that case.
Okay. We have a lot of viewers tuning in from Bangladesh. Thank you all for listening in. Dr. Noor Jahan Begum has this question: which patient is perfect for IUI and how much is its success? We have more or less covered this. The success rate would be pegged at anywhere between 10 to 12% per cycle per person. During IUI, this is another question from the respected Professor Laila. During IUI, the follicles do not reach the expected size even after doubling the dose. No hormonal imbalance. AMH is also normal. What next? This is a question I'll address to Dr. Anindita.
So if the patient is not responding to whatever ovarian stimulation we are giving, then we have to, I would like to step up the dose and continue at that dose until the threshold has been reached.
What has been your maximum daily dose that you've got a follicle and a pregnancy?
The daily dose for an IUI cycle have gone up to 150 IU.
So you can safely give 150 IU and continue for 20 days. Even then you can get an ongoing pregnancy. That's the clear message from Dr. Anindita. So you need not panic and we can continue with the same medication in a safe sort of a way. I want to know about ovulation induction of PCO patient not responding to oral ovulation. Dr. Nusrat Jahan asking this question. I would ask Dr. Shatabdi to take this question, please.
For the PCO patients, it's better to directly start off. We can try with a cycle of oral ovulations. If they don't respond, it is better to, rather than adding up gonadotropins after we have seen them on day 10, it's better the next cycle we directly start off with gonadotropins from day 2 or day 3 of the cycle. A low dose, prolonged one, they will definitely achieve a monofollicular growth.
Okay, that's a very clear answer. Thank you. This is a different kind of a question coming in from Dr. Mala. How successfully IUI catheter is introduced, and sometimes it may touch the fundus. Does it cause any harm? This is a technique question. I am putting this question to Dr. Anju.
Usually if the catheter, we should not have any problem. We should have in mind what is the position of the uterus. So before starting the IUI, I always see my old papers, what is the direction of uterus. And the catheter is always a soft and malleable, and the tip should be soft so that it does not cause any trauma. And once
what if touches the fundus, the tip touches the fundus? Do you see any problem there?
I just withdraw. I have never seen, I have never encounter in that. I just go beyond the internal laws and inseminate.
So even in case that you do touch the fundus, there would be some cramping, but that will not cause any permanent damage. There could be some bleeding also, which could be evident on the ultrasound, but it not. I would add here that maybe a mock transfer prior to doing the insemination and an ultrasound guidance would also be helpful in identifying such patients, so that you are extra careful with them. This is the last question, and I would like to put it across to Dr. Shatabdi here. Are you doing infertility treatment in the COVID era? What is the extra precaution that you're taking in this COVID times? This is a question from Dr. Shahnaz Khanam Chaudhary.
Yes, we are doing infertility treatments in these times also. The extra precautions that we are taking is firstly the triage questionnaire. Whenever the patient, we are encouraging patients to take a prior appointment and come to the center rather than just coming one day, so that our people over here can do the triage questionnaire properly, because that is where we are screening if they've had any history of travel, if there is any symptom, and that is how we are, the first part of the screening is done over there. And the extra precautions that we do in the center is their temperature thermal checkup is done. We encourage them all, rather we make it compulsory for them to wear the gloves and everything. Whenever the patients visit our center, after each patient has visited, we are cleaning the chairs. We are also regularly sanitizing our table, our everything over here. We are making sure that we, as well as the entire staff in the center, is always wearing a mask. We are not gathering. We are not doing any gatherings in any part of the center. And most importantly, we have divided our team into 2 or 3 as per the strength of the team, so that even if one team is exposed to some patient who's positive, we will not have to seal down the center. The other team can continue working after we have properly sanitized. And of course, for our ART treatments, we are getting a COVID test done for both the husband and the wife. That is how we are continuing with the fertility.
Yeah, so I would say here that choosing to be treated is the patient's prerogative, and she has a right to choose to be treated. To be able to provide service with adequate safety measures is our effort. And if a patient or a couple chooses to be treated because of the conditions that they are in, because every couple is in its unique position in terms of their planning and their social and other issues, so then they have a right to be treated, and then we are there to provide the treatment to them, provided the basic safety measures are all in place. The triaging, which Dr. Shatabdi refers to, is basically a very elegantly done up questionnaire from our professional societies, ISAR and IFS, which basically helps us to identify patients who are at higher risk and who can then be encouraged to avoid getting treated or postpone treatment till the time that they have a better frame of situation. I would like to conclude here by thanking all my panelists. You've been a wonderful panel, Dr. Hasna, Dr. Anju, Dr. Anindita, and Dr. Shatabdi. It has been a good, nice 1 hour, 10 minutes round of discussion on IUI. Questions are still there, but they will always be there. By and large, IUI is a simple procedure of reproductive medicine, often referred as the first treatment option. The chances of success are commonly overestimated both by the patient and the physician, and this is something that is a stumbling block when a physician starts doing IUIs. Only with proper stimulation, proper medicines, proper monitoring, and proper ovulation trigger, a success of 10 to 15% can be achieved. It is not easy to achieve a 10 to 15% success also in an IUI program. Since the chances of success are greatly influenced by the age of the person, insemination is not a therapy for people who are more than 40, let's say. Likewise, it's not an option with couples with a stronger limitation of sperm parameters. Gynacs and andrologists are encouraged to educate couples with infertility accordingly in terms of a cost-benefit analysis before putting them onto an IUI program. I thank all my panelists once again. Along with that, I also thank Science Integra for this wonderful opportunity given to us with the help of Bharat Serum. Thank you all, the viewers also, the listeners also. Hope to see you again next Saturday at the same time.
Thank you.
Thank you, sir. Thank you, sir.
Thank you.